what is an application as a medical professional that you think might be largest impact towards the COVID-19 response efforts? And I think the question is geared towards, in this hackathon, what are some of the things that you think might be the biggest or best things to build?
Well, that's quite a large question. There's huge system issues within healthcare delivery within the United States that there's no single application, in a unified medical record system or patients owning all their own data would address a lot of these issues, but those are big issues across the board. I'm really, the idea of patient sovereign data and me as a patient owning my own data, I've been an advocate for that for years. I can tell you though that the majority of my clinical colleagues don't agree with that. So that's going to take some time to change. So I think, that patient sovereign data is one of the key things, but also having a network. I look at physicians, providers in particular, as a supply chain issue also. So there's no national system other than what's involved in malpractice and the physician, provider databases that again focused on malpractice. There's no system that can identify me, for example, to say I've got 2 hours free this afternoon and I could do a telemedicine consult with someone anywhere. So there's, networks to plug in all the key stakeholders and pandemics, emergencies within the healthcare ecosystem would make a huge difference, because we can't mobilize the resources that we have because we don't know where they are.
I think it's also a question of timing. In the phases that we're in at the moment, we're in sort of crisis, and there's a sort of McKinsey model of we're in crisis and then we'll go to resilience and stabilize, and then we'll sort of work out how we return to normal, and we all need different things at different points in the crisis. And at the moment, everybody's thinking ventilators and face masks, and it'll move into testing, and then there will be things that later on, like long-term mental health applications, but we will need different things at different points.
I would say, again, there's a myopic focus on the resolution, but at the same time, we have to look beyond what the resolution can actually do in the solution deployment. And if that can actually be weaponized later for communities that usually are disproportionately affected. So again, we have the tracking aspect, but how does that, where does it go after we solve this problem? That needs to actually be considered before, during the deployment phase, because yes, we're very much making sure that it works very well right now, but after the pandemic goes, what happens after that? We need to be very cautious of the solutions, that they are appropriate, and also that they, like I said, do not disproportionately affect different people at different times.
There's a lot of talk about the new normal that's going to be coming, but I think that there's a real normal that was a sort of pre-COVID, and there'll be a real normal post-COVID. That normal is not what we sort of should be looking to get back to, because as we pulled the Band-Aid off, as COVID has helped pull the Band-Aid off of a number of different issues around health equity, around issues of access, around issues with respect to a number of different determinants of health and health outcomes, we can't sort of put the veil back over it and say, okay, we're post-COVID now, we don't have to deal with that stuff anymore. I think if anything, COVID has helped in a sense, and in a very unfortunate sense, us identify and see where those issues are. And so hopefully through the course of our conversations and the work that we do here and afterwards, we can address some of those issues for what's the real new normal, and sort of not continue to sort of push certain communities, certain populations under the rug, even though some of those communities and populations drive our healthcare costs very significantly. So
I think one of the things that I'm beginning to see almost daily is that today, because of the acuity of the instances of the encounter between the clinical team and the patient presenting with COVID, you don't really have much of a pre-existing knowledge base of the individual. Therefore, you have to capture very quickly the patient's story, which is almost impossible to do because of their clinical presentation. So you have to do a lot of piecemealing of previous clinical histories in a high acuity intensity area, and then make some life decision choices about their care based on less than good information. So I think, when people say, well, what is it that we can conceptually think of? imagine you having to take care of somebody that you don't know or that you've never taken care of. Now you have that responsibility, and now you have to capture their patient's story and know their patient's history to take care of them. Well, COVID has amplified all that scenario. And so, and so let's pretend that I took care of that individual, and then there's another team that's going to take care of that individual. How do we reconcile that information so that it's persistent, its provenance is guaranteed, it's secure? So all those kind of technology enablement attributes of blockchain that in this particular case are amplified, I think, that's something worthy of consideration for the group.